Good morning, everybody. This is Neil Theise, your friendly New York neighborhood liver pathologist. Thank you for coming in and joining us this is our fourth liver pathcast. And I've had a bunch of requests for different topics. I apologize to the resident from Mount Sinai who stopped me in the elevator and said, could we do liver cancer? And I said yes, but then you were outvoted by the local residents who wanted autoimmune hepatitis. So we'll do liver cancer stuff next time. Special shout out to Susan Carol Tim. Congratulations on your first anniversary of your liver transplant for primary biliary cirrhosis. Primary biliary cholangitis, the new name. And Susan is a patient whose liver biopsies I got to look at prior to her transplant. And we're friends on Facebook, and she's done amazingly well with her transplant. And today is the 1-year anniversary. And she likes logging in to learn liver pathology, which is kind of amazing and wonderful. So on occasion, pathologists do meet their living patients, not just pieces of their patients, which is extra nice. So autoimmune hepatitis. First, I'm going to do a little short few slides didactic to show you graphically how I think about things and how this is different than chronic viral hepatitis, because I think that's essential. Understanding that difference is essential to knowing how to assess a biopsy where autoimmune hepatitis is in the differential. And then we have 4 cases that we'll look at. So, procedure. There's a little bit of a time lag between YouTube and us, so of about 15 seconds. So rather than ask for questions and then wait for that lag to reach you and then come back to us, if a question arises, either during this little didactic bit or during each case, just hit the YouTube chat button or chat bar and type your question in. And so if there are questions when I get to the end of that particular section, we'll take a few of them and answer them immediately and reduce lag. So as you think of a question, don't hesitate to type it in, even if it's in the middle of me talking. It won't distract me. So now, how do I would just do it like a normal PowerPoint. Okay. So autoimmune hepatitis, the standard basic clinical stuff that you should have learned in medical school, it's worth reminding you. Mostly this happens in women, sort of, the way rheumatoid mostly happens in women, and PBC happens mostly in women, and scleroderma and Crest syndrome and Sjögren's syndrome and things like that. Typically, it presents in the 40s to 60s, and autoantibodies in the serum are characteristic, particularly anti-nuclear and anti-smooth muscle antibodies, though anti-mitochondrial antibodies can be seen as well. And particularly in younger patients, there's a autoimmune hepatitis type 2 whose peak age is actually in the 2nd and 3rd decade of life, in which anti-liver kidney microsomal 1 autoantibodies predominate. But all of these should be investigated, and all of these should be taken into consideration when assessing a patient for any autoimmune liver disease, but particularly autoimmune hepatitis. And there are occasional patients in whom the classical pattern, ANA, secondarily smooth muscle actin, are not present. That doesn't necessarily mean it's not autoimmune hepatitis. However, if there are no autoantibodies, that's exceptionally unlikely. And you should be very, very, very hesitant to think about autoimmune hepatitis if there are no autoantibodies positive. Serum IgG is also often elevated, and that's also a very important thing. And if there's a case that's sort of borderline on the fence, is it autoimmune or not? Ask about serum IgG, recommend that be done. That can be very helpful. And the presentation in the liver biopsy specimen may be either very severe activity and or very advanced stage scarring. This isn't about how the patient presents symptomatically. This is about how the liver biopsy presents. And the patient can present and be totally asymptomatic. So we'll go into that. That's what this little didactic bit is about. And the treatments are immune suppression, corticosteroids, or Imuran, et cetera, and for advanced stage, end stage autoimmune hepatitis, transplant. So we normally think of chronic viral hepatitis as sort of functioning like this. Hepatitis C, hepatitis B. You have waxing and waning, fluctuating AST, ALT over time. And if you looked in liver biopsies serially in these patients, their necroinflammatory activity would also fluctuate. Particularly in hepatitis C, you occasionally get acute flares of injury, and then it just returns to the normal up and down fluctuating course. The scarring, on the other hand, can either be very slow and very, very mild, so a patient never gets to more than, let's say, a little portal fibrosis. So they have chronic viral hepatitis if they are not treated for years and years, decades, and they don't advance to end-stage liver disease. There's the occasional patient, a minority, that advance very quickly within like 5 years from infection to advanced stage liver disease. But the most significant that we have worried about historically are the ones that over 10, 20, 30 years eventually approach cirrhosis, end-stage liver disease. Our concerns about this and liver biopsy specimens to assess these things has greatly changed in the last year now that we have really successful suppression of hepatitis B with antivirals and cure of hepatitis C almost universally, nearly universally in hepatitis C. We're not going to be seeing these in liver biopsies very often, and these are not going to be common clinical questions because everyone will essentially be treated. The exceptions to that would be another talk. Now, autoimmune hepatitis looks different, even though it is a hepatitis and it is modulated by the immune system and looks individually very similar. The pattern over time is actually very different. So with this, notice that here the degree of scarring does not relate directly to the foci of inflammatory activity. So in most organs of the body, you get inflammatory destruction of tissue, and you expect that's where the scar is going to form. And there's a direct correlation. The injury leads to scarring as part of the repair process. But in viral hepatitis, that's not true. You have little bits of inflammation all over the place, sometimes in the lobules, sometimes at the interface, and those sites don't directly scar down. You just get regeneration of hepatocytes that fill them in. And yet, you wind up getting this sequential development of portal fibrosis leading to portal fibrosepta, leading eventually through distortions of the vascular supply to nodularity, alternating with atrophy, nodules develop, fibrosis develops, etc. So it's a very complex process whereby scar forms in viral hepatitis, and it is not replacement of the inflammatory lesions by scar tissue. It's more likely to be replacement of foci of atrophy because of vascular insufficiency locally with scar and collapse of parenchyma rather than directly to the inflammation. And that's why you have a pattern here that's so disjointed from the different patterns of scarring, the different processes of scarring. They don't directly relate to each other. Autoimmune hepatitis, though, is a bit different. So what happens with autoimmune hepatitis, in the first months to few years, you have this wave of very severe activity that rises and peaks. And this may be entirely asymptomatic, oddly, and then declines to the late stage burned out phase of autoimmune hepatitis in a patient who's been untreated. So the activity in months to first few years of disease rises very high and then fades away over years to decades to a burned out phase. And the scar is a direct response to that necroinflammatory activity. And so scarring begins very quickly, and untreated autoimmune hepatitis almost invariably goes to cirrhosis, and the scar progresses and eventually becomes an advanced stage cirrhotic that's burned out. So this is a very different pattern. And this pattern of activity helps you figure out how to interpret liver biopsies when autoimmune hepatitis is in the differential. Now, historically, it was these patients that were first discovered to have autoimmune hepatitis. So this goes back, I think, to the 1950s, 1960s. Sheila Sherlock at the Royal Free Hospital in London, Dame Sheila, and Peter Scheuer, her pathologist there, Hans Popper and at Mount Sinai Hospital in New York, and Fenton Schaffner, his hepatologist, are amongst the leaders in this field. There were others, of course. And what they first started noticing was there was a population of middle-aged women who were asymptomatic, who present with ascites and are discovered to have cirrhosis. And they had no known infections. And don't forget, we couldn't really identify viral infections up until that time. But these were not people who had had transfusions. So they were non-transfusion related hepatitis. Hepatitis B wasn't discovered until 1968, the virus. C wasn't discovered till I was a liver fellow in 1989, 1990. So there was transfusion-associated hepatitis, some of whom became cirrhotic. And then there was this population of non-transfusion-associated cirrhosis, and they were women, and had been asymptomatic for years. When these women were studied, it was eventually figured out that they had autoantibodies, particularly anti-nuclear antibodies, anti-smooth muscle, anti-mitochondrial. And so this idea of autoimmune hepatitis arose. And they improved, many of them improved when they were treated with immunosuppression. And so that sort of solidified the idea that we had a new disease here that was non-viral, non-infectious, called autoimmune hepatitis. Now that that disease had been classified, they could sort of look out for other cases that were earlier. And so they started finding usually women, not quite as old, but older, who had markedly elevated serum liver tests, in particular serum transaminases. And now that autoantibodies were in the panel of tests to figure out the nature of the underlying disease in a patient who had liver disease, they would look for that. And sure enough, many of these, usually women, a few men, had autoantibodies. And then they realized, oh, these are earlier stages of autoimmune hepatitis. And when they gave them immunosuppressive therapy with corticosteroids, their numbers improved and they got better. And they didn't necessarily progress to end-stage liver disease. So these patients started getting biopsied. And then as the years go by, the sensitivity to this as being a real disease that needs to be watched out for resulted in younger patients still presenting with what looks like acute liver failure. And now these patients were interrogated for serum autoantibodies, and some of them had autoantibodies. And it turns out that they could be put on immunosuppressive therapy. They would get better. And many of these would actually be able to be tapered from their immune suppression after a certain amount of time and remain stably, it's early here in New York City for me. What's the word? Suppressed, but in remission. Their disease would go into remission with a good solid course of immunosuppressive therapy and stay that way for a long time, if not forever. So, so these are the ways in which you see autoantibodies presented. Now, the result is that you never see a biopsy that has little in the way of scarring and little inflammation. Here you have a little bit of scarring, but tremendous activity. Here you have a lot of activity and a lot of scarring, one or the other or both. And here you have lots of scarring and no activity. So these three combinations you see in liver biopsy specimens from autoimmune hepatitis. This you never see. Just a little bit of inflammation and no scarring. And you will get biopsies. Often patient has abnormal liver tests for, let's say, 6 months, and their anti-nuclear antibodies are 1 to 120, and they say rule out autoimmune hepatitis. This is not autoimmune hepatitis if the biopsy only shows a little bit of inflammation and no scarring. The ANA is probably a red herring related to something else in their system, maybe their thyroid, or maybe just that's where their autoantibodies are and they don't have any disease associated with it. And you have to start thinking about a subtle infection that may be self-limited, non-specific. You have to think about a drug or toxin-associated injury, etc. So this approach is helpful in figuring out, is a case, which is often the question for you as a pathologist, is this autoimmune hepatitis or not? Now, I want to also highlight one thing, this severe activity that I talk about. What is severe activity? And if you look at all the grading schemes for necroinflammatory activity, the Ishak Hepatitis Activity Index, the original Nodell Hepatitic Activity Index, the Medivir Activity Index, they all assess 4 kinds of necroinflammatory activity in a biopsy. Portal inflammation, which sort of defines the existence of a chronic hepatitis. Interphase hepatitis, so hepatitic activity at the interface between portal tract or septal stroma and the parenchyma, and lobular hepatitis, acidophil bodies or inflammatory cells, spotty necrosis out in the lobule. We see all of those things in a typical viral hepatitis biopsy, right? But in all of these schemes, particularly highlighted in the Ishak Hepatitic Activity Index, is this 4th category called confluent necrosis. If you don't have confluent necrosis in a biopsy, it's impossible to have, quote, severe activity, close quote, in the Ishak staging system. It's very difficult in the Medivir system to have severe activity if you don't have confluent necrosis. And so when I talk about severe activity in autoimmune hepatitis, I'm often talking about, nearly always talking about confluent necrosis. What is confluent necrosis? So here are the portal tracts. An inflammatory infiltrate in the portal tracts. Here's the central vein, and the hepatocytes around the central vein have dropped out in an area of confluent necrosis. If this gets increasingly, if this increases, you eventually have bridging necrosis. That may be central portal or look portal, though if you look really carefully, you'll often find that it's passing through a central vein. And then eventually total parenchymal collapse, the parenchyma just dies. So all of this, from the most mild version of it to the most severe version of it, all of this is severe necroinflammatory activity called confluent necrosis. And it looks like this. Here are hepatocytes, and here's a central vein, and you can see there's this zone of mush, necrotic debris, and inflammatory cells and macrophages coming up to the central vein, the hepatocytes get near the central vein, but don't make it all the way to it, and then you have this zone of confluent necrosis, perivenular confluent necrosis, okay? This is severe necroinflammatory activity. And notice that there are lots of plasma cells. This actually is a case of autoimmune hepatitis. This is a case of hepatitis B. On an H&E, this looked like a cirrhotic liver, but the Trichrome Stain shows it's clearly not a cirrhotic liver. Here's the dark blue of the pre-existing stroma of the portal tracts, and you've got bridging necrosis between them, very early loose collagen deposition just starting, ductular reaction, that's a stem cell response. And this was a case of hepatitis B with a new superimposed delta infection. Okay? Now you can imagine that this would scar down very quickly, and the patient would go straight from no scarring to cirrhosis. And that's the kind of thing that's often happening, we think, in autoimmune hepatitis. This is direct scarring of confluent necrosis leading to advancing fibrosis very early on in the stage of disease. Okay, so any questions come through on this stuff? Not yet, apparently. Okay, so now I'm going to show you 4 cases. Hold on, finding my case. Okay. Is this in focus? Yes. Okay, good. So this is a 52-year-old woman, ANA, anti-nuclear antibody positive, anti-mitochondrial antibody positive, IgG elevated, IgM elevated, alkaline phosphatase 400, ALT, AST 250 to 300, rule out autoimmune hepatitis. The IgM was a question that came up later, and I added that, and we'll see why they looked at it in a moment. But first, oops, dust, sorry. So we see that there's a lot of inflammation in this liver. At low power, it's not subtle. Some areas diminishes, but a lot. So it's a very active liver. I'm sorry, I should have cleaned my slides last night. I was not paying attention. Very inflamed. And here we have a central vein. And here, I think we've got a portal area and inflammation bridging between them. I think this is bridging necrosis. And if we look carefully, plasma cells are pretty easy to find. So plasma cells and autoimmune hepatitis. If you're studying for a pathology board exam, those two things go together. Autoimmune hepatitis and plasma cells and autoimmune hepatitis, they go together. However, probably 50% of autoimmune hepatitis biopsies have a plasma cell predominance and 50% do not. So if you see them, that supports your diagnosis. If you don't see them, that does not make autoimmune hepatitis unlikely. Half your autoimmune hepatitis biopsies will not have plasma cells that you like to see. But for the board exams, think plasma cells. See more plasma cells here. So I think there's bridging necrosis, which is severe activity. And there's lots of interface and lobular hepatitis. So this is one of the occasional cases where the lobular and interface hepatitis, here's all this interface hepatitis over here, that alone probably would get you pretty close to severe certainly by Medivir staging. Ishak would get you to 12 of 16, 12 of 18. Confluent necrosis is required to get to above 12 points. And again, here, look at all these plasma cells. The senior pathologists, residents watching, should be able to see those at low power. Junior residents need to go to higher power. Plasma cells, lots of plasma cells. Okay, so then we look at a Trichrome Sting. And there's a portal tract that seems uninvolved. However, now this is a very large scale portal tract. I wouldn't be surprised if this patient, look at this nerve getting severed. This patient probably screamed during the biopsy. But you can see that there clearly is fibrosis, fibrosepta, and focal nodularity. So I think this is a transition to cirrhosis in this case. And not all of it is cirrhotic, so that's why I call it a transition. That would be an Ishak stage 5 of 6. That would be a Medivir F3 to F4, a modified Ishak of stage 3. That's Ludwig stage 3. So that puts us in this category. Transition to cirrhosis, very active disease. This is a biopsy that's compatible with autoimmune hepatitis. And that would be sufficient to characterize this liver biopsy, except there is a second slide. And when we look at the second slide, yeah, I got it. Thank you, Rifat. There was a surprise. A beautiful, whoops, diagnostic duct destructive lesion of primary biliary cholangitis. That's for you, Susan. So here's a duct that's relatively intact. It's probably looping around, and over here, this duct is being completely chewed up. So on the basis of this, I said, I think this patient also has overlap primary biliary cholangitis. And they went into the serum IgM, and it was elevated. And that explains why the alk phos is 400. So this patient has overlap, autoimmune hepatitis and PBC. Okay. Any questions? Very comfortable to make this diagnosis if I think about that scheme of how fibrosis and activity relate to each other. I know where this case is in the course of this patient's disease in terms of that graph. So that makes me comfortable making the diagnosis. Did any questions come up?
Not yet.
Okay. So don't forget to write your questions as they occur to you. So at any surprise moment when I decide I've said enough about a case, the question will be waiting for me. Because otherwise, we're just going to go on to the next case.
So this case was an overlap syndrome.
This was an overlap syndrome. People in the room, what's the therapy for this patient?
Steroid.
Corticosteroids, possibly, and or Imuran, some other immunosuppressive therapies that may be in use now that I'm not aware of or are coming down the pike. Will that help with the primary biliary cholangitis?
No.
No, it won't. For PBC, we give ursodeoxycholic acid, and that will slow it down. But immune suppression does not work for PBC. So you need both methods of treatment. Someone in the room whispered transplant. Not yet, because if this patient is well suppressed with both diseases, she will not likely progress with scarring. And what scarring she has, if she remains in remission, is likely to regress. So she may live quite long enough to have some other thing that's going to give her problems. Of course, being on immunosuppressive therapy for the rest of her life, that's not a trivial thing too, and that can lead to side effects that can in some cases be lethal. Think about osteoporosis. She's 52 years old now. She has 20 years on corticosteroids to keep her autoimmune hepatitis at bay. She's going to be probably severely osteoporotic in her 70s, and that puts her at risk, et cetera, et cetera. So the treatments are not trivial either. Okay. So the second case is a 45-year-old woman who has, the usual not great information. Moderate ALT, AST elevations, they weren't specified. ANA positive, an IgG elevation, and she was empirically put on therapy with prednisone and without a liver biopsy. Yes?
So there is a question. BS Dugan Ken Hip has a question. What is cobblestone appearance criteria for this lesion? And AIH, she says that she read in some book, but had to find it in PubMed. She's stricken from Japan.
Thank you for your question. I have no idea what cobblestone appearance is. I suspect what it might mean, one of the things that's described in autoimmune hepatitis is this kind of thing, where you have, the description I've heard from my teachers for it is hepatocyte rosettes. You have little round islands of hepatocytes surrounded by inflammation. And I think this may be called by some people cobblestoning. Any hepatitis where you have really severe interface and lobular hepatitis, I think you get this sort of thing. So I think it goes along not particularly with autoimmune hepatitis per se, but with severity of hepatitic activity. And since B and C in biopsies are rarely as severe as autoimmune hepatitis is, it's associated less with them than it is with this. So I don't know that this is what they mean by cobblestoning, but I suspect this is what they mean. The other term for would be hepatocytic rosettes, not like cholestatic rosettes, where you actually see the canaliculus dilated in the middle with bile. We don't see that here, but these sort of little islands of hepatocytes. So that's my best guess. And I don't base a diagnosis of autoimmune hepatitis on that. I base it on the degree of activity and the degree of scarring. Plasma cells are nice, and the absence of any other particular liver disease that might be actually causing the liver injury, with autoantibodies being a red herring. So I'm excluding other things and trying to fit it in clinical pathologically with what the patient has on the biopsy and clinically. Okay? So 37, oops, sorry, shouldn't say numbers. So this is this woman who has autoantibodies and had been treated presumptively for autoimmune hepatitis without a biopsy. She did not normalize her serum transaminases, so they wanted to make sure she didn't have something else. And sure enough, she's got very severe activity. And so here, look at this. This is nice. This is a central vein. This is a portal tract. See, there's the bile duct, the artery, and the portal vein. This is another portal tract, I think. And there's no parenchyma. The hepatocytes are gone. So parenchymal collapse. Here we've got a central vein, a longitudinal cut. It's a good sized, big central vein. And look how you've got this dropout of hepatocytes all around the central vein. The hepatocytes come to here and then stop, like that picture I showed you. So this is really severe activity, confluent necrosis with parenchymal collapse focally. Central veins and portal tracts just collapse together with all the liver parenchyma in between gone. And you see it's not as inflammatory looking as that other one. It looks sort of empty of inflammatory cells. Well, that's because she's got a blast of prednisone. But this prednisone has clearly not suppressed the injury completely. The injury is ongoing. So this is an incompletely treated autoimmune hepatitis. But we've got the severe activity. And we've got a lot of biopsies. So portal tract with some inflammation in it. Not as much as you expect, but she's had partial treatment. Uninflamed portal tract. So notice it isn't always completely uniform. And then we look at the trichrome stain. Oh, in this case, the trichrome stain was a serious red and it didn't work too well, I think. It's a little on the pale side. Yeah, so that's poorly stained. So reticulin stain, I think, was helpful on this one. So certainly highlights that parenchymal collapse we were seeing. Oh, dirty slides again. I apologize. My prep for this was a little hurried. So there's some scarring, but mostly looks like there's some portal expansion, but most of the confluent necrosis has not really scarred over. It's empty of dense collagen deposition. So a little bit of portal tract scarring, but Not much. So this I call chronic hepatitis, severe with bridging necrosis and focal parenchymal collapse with mild portal fibrosis. And so this would be an example of this kind of injury. Mild portal fibrosis, but very severe activity. And it would be compatible with partially treated autoimmune hepatitis. And this is a patient who either needs more corticosteroids or more likely they would add on something, a more direct and specific immune suppressive agent like Imuran.
And how often are you getting these biopsies?
Pardon?
How often is this patient getting biopsies?
Not often. This was probably the only biopsy.
So how do you follow it?
Oh, do you follow it clinically? Yeah, yeah. The numbers, a successfully treated autoimmune hepatitis patient, the numbers should normalize. If they don't normalize, then you're suspecting some other disease. And the most common way in which they don't normalize, though it doesn't happen often, is their ALT, AST comes down to normal, but their alk phos remains elevated. And then you're thinking overlap PBC. And then it's worth going back to look at the original biopsy to see if you missed that. The last time I gave one of these pathcasts, we talked about keratin 7 and keratin 19 picking up a very subtle early PBC. And there have been cases where I've gone back to a prior autoimmune hepatitis and reevaluated it with the special stains. And sure enough, there's the PBC. And I hadn't seen it initially because the AIH was concealing. And then the patient gets put on URSO and everything normalizes. There is another important circumstance, though, and that's the next one. So any other questions come up?
No.
Okay. So this is a 60-year-old woman, ALT, AST in the 400s, anti-smooth muscle, antibody positive, anti-nuclear antibody positive. Hepatitis viruses are negative. That always needs to be part of the clinical picture. If you don't know that, you ask the clinicians, what about viral testing? They're doing it in all these patients. They just might not tell you, but you can't make a diagnosis of AIH without getting that information too. I should have said that earlier. And their question was autoimmune hepatitis versus drug toxin-induced liver injury, DILI. Because the patient was on lots of stuff and taking lots of stuff, shopping at the local dietary supplement store, shall we say. So this case. Could you hear the slide dropping? Mercifully, you didn't hear the slide cracking. I have rolled over slides. Okay. Low power, very, very, very inflamed, very disturbed biopsy. Oops, sorry. There we go. Okay. So we see lots of inflammatory activity. Here's a portal tract, which we can tell because there's a bile duct there. Oops. Inflamed portal tract. Plasma cells galore. There's the bile duct. Can you see that was that in the picture? Yes, okay. And then bridging necrosis. Is this a vein? So this is another portal tract. There's the bile duct. So there's bridging necrosis between portal tracts. And then to here. Here's a central vein, and there's dropout of hepatocytes around the central vein, so severe confluent necrosis. There's also some pigment here. The hepatocytes are cholestatic. There's bile pigment in the hepatocytes. So this is a very cholestatic biopsy, as well as being very hepatitic. And so there seems to be a mix of hepatitic and cholestatic features. Wow, look at these plasma cells. This is like pus made of plasma cells. Lisa Yarian showed data at USCAP, I think, several years ago that in autoimmune hepatitis, the plasma cells are IgG positive, and in PBC, they are IgM positive, mirroring what we see in terms of elevations in the serum. Those are difficult stains to do as diagnostic things, but her research was, I don't know if she published it as a paper, it was certainly an abstract that I saw her present. So that's an interesting correlation. And again, bridging necrosis. So really severe activity. So this could be autoimmune hepatitis. But we also have that question of drug toxin-induced liver injury. Let's look at the scarring. So this is a bit of a dark trichrome stain. I don't think that there's really a tremendous amount of collagen deposition in here. I think it's just a little bit overstained. Portal tracts look normal size. So this is the sort of thing, I didn't have the reticulin stain in file, but I probably correlated that with this because I said that there was no significant fibrosis. I think this is just a dark, overstained trichrome. So is this autoimmune hepatitis? Or is it drug? What is in favor of either one of those? People in the room. So that goes with autoimmune hepatitis. Could that go with drug? Yes, because sometimes drugs will initiate an autoimmune hepatitis. And you can withdraw the drug and it might go away. Or you can withdraw the drug and it doesn't go away. And it actually has started up an autoimmune hepatitis that's going to happen on continue on its own. And needs to be treated like autoimmune hepatitis. And it's even stranger because some of those cases that are drug-induced autoimmune hepatitis do not respond to to immune suppression. So there's a whole range of possibilities that can happen with a drug toxin-induced liver injury that can mimic or actually be autoimmune hepatitis. And the clinical response may or may not be like autoimmune hepatitis. It may go away with withdrawal of the drug. It may persist. If it persists, it may respond like autoimmune hepatitis to immunosuppressive therapy, or it may not. So what favors drug toxin-induced liver injury in this patient? The cholestasis. So autoimmune hepatitis, those other cases did not look so cholestatic. The hepatocytes were not so bile stained. And so if you have a mixed hepatitic cholestatic picture, there are very few things that do that. Drug toxin-induced liver injury and overlap PBC autoimmune hepatitis are the primary things. And DILI is far more common than overlap autoimmune PBC. So in this case, it's not entirely clear. And I cited out question mark DILI versus AIH because I can't be definitive on the basis of the biopsy. And then it's up to the clinicians to figure out what to do. And step one is get them off anything that might be a toxin that could be driving this injury. And if they do and the numbers get better, question answered. If they do and the numbers don't get better, then you have to treat it presumptively like on autoimmune hepatitis and hope that works. If it doesn't, that favors that it was a drug-induced initiated process, but that's their clinical correlation several steps down the road. So from a pathology standpoint, this is compatible with AIH because it's in this box. It fits, but it has the cholestatic features and the clinical history that she's taking a lot of supplements and vitamins and herbal remedies and stuff like that. Okay? Any questions on this come through?
We have a question, maybe you can indirectly from the same person in Japan.
Another question on the term central venulitis and central perivenulitis. Are they synonyms? I don't know. the imprecision of liver pathology terminology in the literature. What do we mean by these things? You know, I could do half an hour on different things. Basically, in any sort of hepatitic process, if you look very carefully, you will find endothelial injury and injury more generally, not only to the endothelium of veins and sometimes arteries, but of the walls of those vessels, the basement membranes underlying the vessels, and in this case, the hepatocytes around the vessels. And people are just not precise about their use of the terminology. Usually depends on who taught them and who taught them and who taught them. They're not well defined in the literature. These are not details I need to make a diagnosis. If I go look carefully at each one of these specimens, I'm sure I will find evidence of venulitis, which I would use more typically the way it's used in transplant rejection, which is I want to see the endothelium being undermined and attacked by immunocytes. So I tend to restrict it. I don't use the term venulitis. First of all, I say endothelialitis because it's the endothelium that's being attacked. And I restrict that really to discussing cases of cellular rejection. If you're studying this academically and you want to look for these lesions, sure, but you notice I didn't need to say anything about that in order to make a diagnosis clinically. So to me, these terms aren't that important. I wouldn't worry about it too much. Which? Oh, another term is perivenular necroinflammatory, usually seen in acute autoimmune hepatitis. How to distinguish? Perivenular necroinflammatory activity is what I'm calling mild confluent necrosis. Confluent necrosis is a variant of necroinflammatory activity, and it's perivenular. Therefore, it is perivenular necroinflammatory activity. Okay. And then that person said, sorry, I am a new pathologist. No apologies. We were all new pathologists at one point or another. Okay, last case. 74-year-old woman, mildly elevated serum transaminases, twice normal, ANA positive 1 to 120, hepatitis virus negative, question mark autoimmune hepatitis. So this is a very fragmented liver biopsy. I don't know why. You see fragmentation and you start to think right off the bat, ooh, could this be a cirrhosis? Because they tend to come out in tiny little pieces as parenchymal bits separate from the fibrous septa, but that's not the case here. There is a little bit of inflammatory activity. I think this is a little portal tract and it's inflamed. There's a little bit of lobular activity. You know, in the old days, meaning a year ago, you'd see a biopsy like this in a patient, hepatitis C positive, grade and stage. And you'd have no problem saying this is, oh, minimally active hepatitis C with no fibrosis. As one of my mentors used to say, ipsy pipsy inflammation. Oh, here's a little bit more inflammation. So some interphase hepatitis. Portal tracts, I mean, the bile duct's totally fine and dandy, but there is some interphase hepatitis. And this is one of those cases where the trichrome didn't work, but the PASD can be helpful. And you see that there are some medium-sized portal tracts. This is an older woman, so this is probably normal amounts of stroma for her age. Oh, look, we've got a focus of pigment-laden macrophages. So there's been some lobular activity over here, but it's not confluent necrosis. It's not a whole big zone, and here's the vein. It's just lobular activity. So there's a little bit of lobular activity and a little scant inflammatory infiltrates in the portal tract. Is this autoimmune hepatitis? The clinician thinks so because the patient has an ANA positive 1 to 120. And if you are the kind of pathologist that doesn't understand autoimmune hepatitis, you will roll over and bow down to the clinician's expectation that this must be autoimmune hepatitis. And you'll go, oh yeah, it's very mild autoimmune hepatitis. And this patient will go on immunosuppression and be at risk for all the symptoms that go along with immunosuppression. But we're talking about a patient down here. This is not a patient who has autoimmune hepatitis. Maybe they've got a little non-specific, self-limited, non-hepatotropic viral infection. Maybe they had a little toxic exposure. Maybe they were on an antibiotic for some infection. Maybe they changed jobs and they had a little solvent exposure or something. Drug toxin-induced liver injury. But this is not autoimmune hepatitis, and this is not a patient who should be put on immunosuppressive therapy. And of all the patients, and I get biopsies like this, I'd say once every 2 or 3 months, rule out AIH, positive autoantibodies, and I say, no, the activity is too minimal and there's no significant scarring, so can't be. None of those patients in 25 years of practice have come back to me, has the clinician come back to me and said, hey, we need to rethink this, they're getting worse. Those are patients who generally resolve spontaneously, and I never hear from them again or their clinicians. So I'm perfectly comfortable saying, no, this is not autoimmune hepatitis. And if I have my concept of how necroinflammatory activity and fibrosis relate to each other, if my concepts of that were stuck in how I think about viral hepatitis, I would say, I guess this could be autoimmune hepatitis. But because I know what autoimmune hepatitis works like, and it's different, I know that there is no case of autoimmune hepatitis that's going to look like this. Or if there is, it's exceptionally uncommon. And this is a patient who should not have her health compromised by being put on immunosuppressive therapy, short or long term. Okay. Any questions?
There is one question from Wei. So Wei is asking about the previous.
Do you mean our way?
Yeah.
Oh, she's one of our residents. Okay.
So she's asking what's the autoantibody level for this case, the previous one?
This current one I just talked about, 1 to 120. So levels of autoantibodies. First of all, there are new ways of giving numbers for autoantibodies that are like a number, 50.3, for example. I don't understand these at all. And I need to go talk to a clinical pathologist to find out how they've changed this. I'm used to thinking about titers. 1 to 80 to 1 to 120. Yeah, if that's all I've got and everything else fits for autoimmune hepatitis and the IgG is elevated, that's okay for autoimmune hepatitis. 1 to 120, 1 to 140, 1 to 160. I'm not going to buy that as a serious positive test. And I'm not going to base autoimmune hepatitis diagnosis on such a test. 1 to 120, that's serious. That's getting up there. 1 to 1, 1 to 240, 1 to 1280. Yes, those are serious tests. But if the biopsy doesn't say autoimmune hepatitis, it may be because they've got incipient Hashimoto's thyroiditis. And the liver is actually related to an unsuspected hepatitis B or alpha-1 antitrypsin deficiency or a drug or toxin-induced liver injury or. So I don't let the, if you're thinking like a general pathologist, you're going to be driven by the autoantibodies and you may overdiagnose things. And this is a disease where overdiagnosis can lead to serious consequences for the patient because corticosteroid therapy is not easy. Immunosuppressive therapy in general is dangerous. So you don't want to overdiagnose this. If you're thinking like a liver pathologist, you're informed by the autoantibody information, but you're not driven by it. The biopsy has to really match. And so AIH is one of those liver diseases. The diagnosis is almost always a clinical pathological correlation. The findings of pathology typical for it, but without the clinical findings, it is not AIH. Think virus, think drug, think something else. If the clinical findings look like AIH, but the biopsy doesn't match it, the clinical findings are red herrings. The liver is doing something else. look at what the liver is showing you in the biopsy. So it's always a correlation between those two things. 50-50. The clinical is not more important than the pathology. So in this last case, the clinical, which smells of autoimmune hepatitis, does not drive the diagnosis.
So,
Yes, Rifat.
So what we understand is that basically we don't see a liver biopsy where there are just a few plasma cells and we start thinking of autoimmune hepatitis. We should not. Right?
No, right, exactly. And in fact, it should be noted that plasma cells are just as common in primary biliary cholangitis, PBC, as they are in AIH. They just weren't paid attention to in the early days so much. And as Lesion showed, and maybe others have shown subsequently, if you look at the IG production of those plasma cells, they are IgM positive in PBC, just like IgM is up in the serum. And in autoimmune hepatitis, the plasma cells are IgG positive predominantly, just as the serum IgG is elevated. But yeah, a few plasma cells does not make it AIH. And the absence of plasma cells does not exclude that diagnosis.
There is one more question from Japan.
One more question from Japan. Screen went dark. Uh-oh. Show chat. Some AIH present both clinically and histologically like acute viral hepatitis. To use the term acute AIH in this case. You know, but it's not an acute disease. It's a chronic disease by definition, and you never really know how long it's been there. So no, I mean, you can say compatible with acute presentation of AIH because it is presenting acutely. But was it, you know, had you done a liver biopsy, had you done serum tests on that patient 6 months, a year, 2 years earlier, would you have found incipient disease? Quite possibly. I mean, don't forget that the original cohort were older women with end-stage liver disease who had never been symptomatic. So I tend to not say acute versus chronic. Autoimmune hepatitis, by definition, is a chronic disease. I will say acute presentation of autoimmune hepatitis. But then we're just playing games with words. If you understand the process of what's happening, the words don't really matter. Yeah, the follow-up in the medical literature, this seems controversial, and it is. I mean, there is no great standardization of this, and maybe we're coming up on a time with the changes in PBC and better understanding of autoimmune hepatitis. Maybe pathologists need to start thinking about. I'm big on consensus conferences to standardize nomenclature. And maybe this field is ripe for something like that. I don't know. It's an interesting question. All right, so I guess that's it. 9 o'clock. Thank you very much for joining us. And if you know anyone who wants to watch this, there will be the video remains on YouTube, so people can follow up later. Thank you.
So this is our next podcast tomorrow.
Oh.
Dr. Wennig.
So Dr. Bruce Wennig talking about oral pathology, one of the world's greatest, terrific teacher. Tune in tomorrow at 8 a.m. for oral pathology.
He has got 14 cases.
I bet he talks less about them.
Thank you.
So do you want me to leave these slides up here so you can, I mean, be honest, if some people want to look at